Good morning, everybody. You all are welcome to the CCP Speciality Update in Hematology. This is jointly organized by the Ceylon College of Physicians and the Sri Lanka College of Hematologists. And as you are aware, today and this month is the month of hematology and the month of December as well. And I'm having a privilege of co-chairing this session with Dr. Dhammika Gunawardena. She's the president of the Sri Lanka College of Hematologists. And without any delay, I cordially invite Madam to introduce the speakers today. And
welcome to the Hematology Speciality Update today. I thank the College of Physicians for giving us this opportunity. So we have 3 speakers lined up today talking about very timely, interesting topics. Our first speaker is Dr. Manu Vimalachandra. Manu has been on stage a few weeks ago before talking about amyloidosis. Today he's going to talk about a practical approach to starting Dwack. Manu is MBBS diploma in hematology, MD clinical hematology, MRC PUK, FRC PATH. He's a lecturer and acting clinical hematologist, Department of Pathology, Faculty of Medicine, University of Colombo. He's also the secretary to the Sri Lanka Clinical Trials Registry, and his research interests are bone marrow failure syndromes and hematological changes in tropical diseases. So I'll invite Manu Vimalachandra to deliver his talk on a practical approach to starting direct oral anticoagulants.
Thank you, Madam. And I'd like to start by thanking the College of Physicians for giving us this opportunity to share some aspects of hematology today. So my topic is a practical approach to starting Dwack. This is the outline of my lecture. So I'll start with a small introduction to Dwack or NOAC. So is it Dwack or NOAC? To find out that, we had to go back to 1954. That's when warfarin was introduced. So for about 50 years, we didn't have any other alternatives for oral anticoagulant drugs till in 2004. The first direct thrombin inhibitor went into clinical trials, but it was rejected because of hepatotoxicity. And in 2009, dabigatran is the first of the oral anticoagulant alternatives to warfarin. So because of that, they were started calling novel oral anticoagulants or new oral anticoagulants, and the acronym NOAC came into being. After that, every 2 years, we got new anticoagulants. So then came rivaroxaban, then apixaban, followed by edoxaban. So after some time, they were not novel or new either. So then they started calling them direct oral anticoagulant drugs. Then the NOAC thing came back, this time calling them non-vitamin K oral anticoagulant drugs. So whatever happens, it's Dwack or NOAC, you will see them used interchangeably. So what are the drugs we have? So we have inhibitors of thrombin, which is dabigatran, which is required for the final conversion of fibrinogen to fibrin. Then we have anti-10A or activated 10 inhibitors, rivaroxaban, apixaban, edoxaban, and batrixaban. So the XA here stands for 10A from your clotting pathway. So you can remember that. Now, what is great about these new oral anticoagulants is that you don't have to routinely monitor their response. They have less food and drug interactions as compared to warfarin. Now, we have 2 Dwacks available in Sri Lanka, apixaban and rivaroxaban. But the issue is there is no head-to-head comparison between the 4 main oral anticoagulant drugs. Therefore, when it comes to starting a patient on Dwacks, things can be a little bit difficult, and you might want to know a bit of knowledge to make sure that you give the right drug to the right patient. So these are the indications that have been approved by the EMA as well as the FDA. So just to go through them one by one. So the first one was prevention of VTE post-orthopedic surgery. Then for treatment of acute VTE, both DVT and PE during the initial stage of 3 to 6 months. extended treatment that is beyond 6 months, even if you're taking lifetime at a lower dose. Then the prevention of stroke in AF, treatment of acute coronary syndromes in the acute phase, as well as chronic coronary artery disease and peripheral artery disease. So there's license for DOACs for all these indications. Now, if we look at the data first, what we have, I think it's worthwhile spending some time. So these are the main pivotal trials for atrial fibrillation: RELY, ROCKET, Aristotle, and ENGAGE. One thing I wanted to just draw your attention to is this thing called time in therapeutic range. So that is a percentage of the amount of time patients were on INR. This usually we'd expect a figure of more than 70 as pretty good. But what you see here is in these comparators, so all these DOACs were compared to patients on warfarin. They are quite close to that 70 mark. So what I want to say is that these DOACs were compared to a group of patients who were fairly doing well in their INR values. So dabigatran was checked at 2 doses, 110 and 150. It was equally effective at 110, superior at 150 in reducing recurrent stroke. Rivaroxaban at 20 milligrams were equally effective. It was a non-inferiority trial. Same with apixaban and same with edoxaban. There were 2 doses, 30 and 60. Both were equally effective. When it comes to bleeding, in dabigatran, the lower dose was in terms of superior to prevent bleeding, but the higher dose of 150 had higher bleeding risk, especially GI bleeds. Rivaroxaban also had lower incidence of hemorrhagic stroke or ICH, etc., those sort of bleeds, but increased risk of GI bleeds. Apixaban did not have any GI bleeds or intracranial bleeding risk. Edoxaban, the lower dose did not have an increased bleeding risk, but the 60 milligram dose did. Another interesting point when it comes to the AF trials is the valvular heart disease group. Atrial fibrillation secondary to valvular heart disease was quite poorly represented, about 20%, 14 and 26. Even in that, there was no moderate to severe mitral stenosis patients. Then we go on to the randomized control trials that looked at DOACs in VTE. So you have Remedy Resonate looking at 2 doses of dabigatran, then Einstein and Amplify. The third or the last one is called Hakusi. That is the one that compared edoxaban. All of these trials were non-inferiority trials. So they showed that the DOACs were equally effective in preventing recurrence of VTE. When it comes to bleeding, dabigatran and rivaroxaban had similar bleeding episodes as compared to warfarin, whereas apixaban and edoxaban had a better bleeding profile. So in summary, if you look at these trials, but the driving point is that in terms of anticoagulation, DOACs are probably equally effective. They're not superior, that we know. In terms of bleeding risk also, there's a marginal benefit. It is not really fantastic. So keeping that in mind, the only time where the anticoagulation benefit was in patients with cancer. As you can see, the recurrence rate was reduced significantly compared to this is low molecular weight heparin. So how did that happen? So first they compared vitamin K to low molecular weight heparin, and low molecular weight heparin was shown to be superior in terms of preventing recurrence of cancer-associated DVT. Then they compared low molecular weight heparin to the DOACs. And again, it was equally effective, and there were some studies that showed that it was also beneficial. It's pretty obvious why those findings came, because if you think of cancer patients who are on warfarin, they have very poor appetite, they have vomiting, they are always on antifungals, antibiotics, they are frequently on IV antibiotics. So there's no surprise that cancer patients don't do well on warfarin. So the only instance where an anticoagulant effect was beneficial in DOACs was only in this patient group of cancer. Right. So having that knowledge of randomized controlled trials, I'll go to the topic of choosing a Dwack. So if you have a patient you think will benefit from a Dwack, I like to go through this process. So first find out, is the Dwack going to be effective in this patient? Next, what is the cost and access to reversal agents? Assess the bleeding risk. What is the creatinine clearance? Any drug interactions that might hamper your decision giving a DOAC or one DOAC over the other. And finally, personalize the anticoagulation depending on the patient's lifestyle and other factors. So let's go one by one. What are the contraindications of DOAC? So the first thing I'll look for is it contraindicated? So if you take atrial fibrillation, somebody has atrial fibrillation secondary to mechanical heart valves, DOAC is a no. Mechanical heart valves in general, you should not give DOACs because there's only one trial, that is dabigatran. They tried at 150 milligrams, which had huge bleeding and thrombotic complications. So mechanical heart valves out, mechanical heart valves with atrial fibrillation also out. Moderate to severe MS, like I said before, they were poorly represented in all the main clinical trials. The reason for that is if you have moderate to severe MS, there will be significant pressure increases in the left atrium, and there will be almost permanent wall changes that will give you a predisposition for intracardiac thrombosis. Therefore, if you have moderate to severe MS, even if you repair it with either a biological valve or a repair, you will end up with that similar risk. So if you get a patient with atrial fibrillation, always go to the echo findings and see if these underlying issues are there. Then we go on to VTE, antiphospholipid syndrome. All the DOACs did very poorly when they were given to APLS patients, especially the ones who had arterial stroke and especially the ones who were triple positive. That is anticardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant. So the final nail in the coffin was apixaban trial also, which is kind of coming up as a more fashionable one, also did poorly with antiphospholipid syndrome. Thrombosis at unusual sites. So what I mean by this is superficial vein thrombosis, portal vein thrombosis, and cerebral venous sinus thrombosis. Now these patients were also not poorly represented in the main trials, but we have emerging evidence that the DOACs are useful in this patient setup. However, a word of caution is when you have especially extensive thrombosis, portal vein, splanchnic vein, all those extensive thrombosis at an unusual site, I would be hesitant to start a DOAC because we don't have enough experience with those kind of thrombosis. Then everybody as a whole, pregnancy and breastfeeding, classical contraindication, but there are very good pharmacokinetic studies to show that it is safe to be given in breastfeeding, and there are 2 clinical trials. So you'd expect this also in the next 1 or 2 years to be registered. Now that will be a huge thing because postpartum VTE is relatively common, and giving the option, an oral option, would be quite useful. Extremes of body weight. So again, patients who were either more than 120 kilograms or BMI of more than 40 or less than 40 body weight were excluded from the trials. And unless you have monitoring of anti-10A levels, it's not a very good idea to use DOACs in this patient group. So the first thing is just see if any of these are there in the patient that you have been referred to start a DOAC. Now, this usually probably comes right at the end in any discussion about choosing a DOAC, but in our context, right now it comes at the top because it is not available in the government sector as far as I know, but probably will be soon. So the cost is about 500 to 600 rupees for the original brands of apixaban and rivaroxaban. When I checked last week, they also said they have a generic for 200 rupees of rivaroxaban once daily. Now that is going to be the trend because all the DOACs will lose their patent in the next 2 or 3 years, and we'll be getting good quality generics coming out. So I think it's safe to assume that maybe in another 2 or maybe 1 or 2 years that we will be able to give good DOACs at a cost of about 200 rupees per day. Now, the other problem is when it comes to reversal. Now, always those who are for warfarin, which is a dwindling number, will say that warfarin can be easily reversed with vitamin K and FFP. And you don't, or you didn't have proper reversal agents for the Dwacks. Now, there are two reversal agents. One is idarucizumab, which is a monoclonal antibody against dabigatran, and adexanet alpha, which is another 10A molecule similar in structure to the Dwack. So what it does is it will go and take over all the excretory sites of the 10A inhibitors, so that your natural 10A levels will increase. Now, availability is a problem. We don't have either of these reversal agents here. And even in developed countries, for a publicly funded health system, adexanet alpha is exorbitant, hugely expensive. So unlikely it's going to get approval. But we have PCC, that is prothrombin complex concentrate, which is a plasma-derived product of factors 2, 7, 9, and 10. Now that, my experience is, you can manage Dwack bleeding quite comfortably if you have this PCC available, but it is not available anywhere. In the teaching hospitals and all the big hospitals it's available. So I think it's a good idea if you have a patient with increased risk of bleeding, just to see how soon in an emergency will you be able to get to a place where there is a reversal agent. Just on the subject of reversing NOACs, for completeness sake, I'll just go through this. So if a patient comes to you with bleeding and on a NOAC or a Dwack or bleeding, the first thing to do is to ask what time you took the drug. Because the good thing about these is they have very short half-lives. So you really need to support the patient for those 6 hours or 10 hours where the drug is going to be effective. Take a blood sample to see the hemoglobin and the creatinine clearance and calculate it and see, depending on the patient's creatinine clearance and the last time the patient took the drug, how long is it going to be there. If it's a mild bleed, you just have to monitor the patient and take off the drug. If it's not minor, anything significant, obviously you'll try your supportive measures by fluid resuscitation, blood replacement, platelet replacement if required, involve the surgeons and the radiology team to see if there's any local compression or something you can do, and also tranexamic acid, anything other than GI bleeds, and maintaining tissue perfusion till that duration goes. For dabigatran, because it has 80% renal clearance, there's option of dialysing. And the other ones, the specific reversal agents, are either the ones I talked about. So if those are not available, you have to go for PCC. So that's just for completeness sake. But coming back to our original structure, so the second thing you have to do is to see if in an emergency, are you able to manage this patient like this. Number 3 is assess the bleeding risk. Now, for any patient who has been starting on anticoagulation, a good practice is to do a structured assessment of the bleeding risk. We frequently use this Hasbred score, which gives 1 point for each of these, which is hypertension, abnormal renal and liver, stroke, bleeding. L is for labor INR because this was originally designed for warfarin patients. Elderly, drugs and alcohol. So the more factors you have, the more risk of bleeding. Now, this is not meant to be used to decide to give or not. You have already decided that you are going to give this patient Dwack. The use of this is to intervene for these risk factors, right? So if the patient had 3 risk factors, say was taking alcohol, poorly controlled hypertension, maybe poorly controlled liver or renal disease, you can intervene and bring those 3 risk factors to 0 and push the number of the probability of the patient getting a bleed significantly, right? So because if you have 9 points, it's about the chance of you getting a bleed is 10 per 100 patient years, whereas roughly it's about 1 per patient 100 years if you have 1 risk factor. So do a structured bleeding risk assessment and intervene if you can. Number 4 is calculate the renal clearance. Now, you can't go by estimated GFR. You have to calculate using the Cockcroft-Gault equation, because again, all the clinical trials use this to modify their doses. So no shortcuts, calculate and see. If the creatinine clearance is more than 90, you cannot, well, it is not recommended to give edoxaban, because they say that the elimination will be too much and you won't have enough drugs. Especially the crowd in US are quite convinced with this, but not the others. Now, why I say that is, out of the DOACs, edoxaban will be the cheapest when we have all of them. So that will be your first go-to DOAC. But if this is more than 90, which is not infrequent, you meet quite a few people who have more than 90 creatinine clearance, you would want to exclude your edoxaban. If you have reduced renal function, then you'll have to dose reduce. If you think about dabigatran, you can go up to 50. After 50, you have to dose reduce. After 30, you can't give. The other three, you can use with caution up to, you can use with the normal dose up to 30 EGFR. And between 30 to 15, it is lower dose with caution. And anything below that, you can't use. Right. Next one is drug interactions. So DOACs all four of them use the P-glycoprotein pathway for elimination. P-glycoprotein is a surface protein which puts out drugs. So it's absorbed in the GI tract. The P-glycoprotein will be putting it back to the lumen. So all four of them use P-glycoprotein. Rivaroxaban and apixaban also has a liver metabolism using cytochrome 3A4. So just go through all the drugs the patient is on, and you have to make sure there are no drug interactions, because these can be significant. Up to 2 times the drug levels can fluctuate if they are concurrently on one of these drugs. So there is a nice comprehensive list in the European Heart Rhythm Association guidelines. I will come to that at the end, where if your patient is on another drugs, you can nicely cross-check with that list whether you can give a DOAC or not. Finally, so you have gone through this process, you come to the business end of things, you are going to prescribe the DOAC. You will also have a discussion with the patient what they would prefer. So the dosing is like this. So if you take dabigatran, it is take twice daily. Apixaban twice daily, edoxaban and rivaroxaban are taken once daily. So that might influence the patient's choice of what they are going to use. Rivaroxaban has to be taken with food, otherwise the bioavailability goes down by 40%. So you have to mention that. That will also influence what type of anticoagulation they'll use. For DVT, 2 anticoagulants, that is dabigatran and edoxaban, has to be covered with 5 days of heparin, right? So 5 days of either unfractionated heparin or low molecular heparin, followed by the standard dose of 150 or 60 in the case of edoxaban. For apixaban and rivaroxaban, there is no IV phase. You give a loading dose. In the case of apixaban, it will be 10 milligrams twice daily for a week and go back to 5 milligrams daily. In the case of rivaroxaban, you give 15 twice daily for 3 weeks, then you go on the maintenance. So again, that will also be something that you would consider when you're choosing your DOAC, if the patient doesn't want to get that IV and so on, and even the cost. Right. Then this thing about minor bleeds. Quite a few patients will have what is called minor or nuisance bleeding, especially females who are having menstruation will have significant menorrhagia with their if they are on DOACs. Now, those sort of patients who have these bleeds, it will be useful to use a twice daily one, because the drug levels are lesser like this, as opposed to getting something like rivaroxaban, where you'll have very high peak blood levels and coming back to the baseline. So those type of patients, you would consider going for a twice daily dosing, or if these problems arise, you can switch later. All tablets can be crushed except dabigatran. So for patients who are finding it difficult to swallow or who are on NG tubes, that's something to consider. Risk of overdose, probably Viroxaban is the best if the patient is an elderly patient who's not good with their medications, and if there's any risk of suicide, because Rivaroxaban has a ceiling effect. After so many tablets, you take 50, after 50 you take 100, the effect of Rivaroxaban is going to be, well, it's going to be significant, but it has a ceiling effect. So there are these little idiosyncratic features for the drugs. These are the main ones, but you probably want to have a good discussion with the patient, giving all this information when you're finally going to decide. Right, so that's what the process I follow if you want to start a patient on Dwack. So first thing is, are there any contraindications? If there are no contraindications, can the patient afford it? Can the patient get to a decent hospital if there is a bleed? Number 3, do a structured bleeding assessment. If there are risk factors you can intervene. Calculate the creatinine clearance, dose adjust. Sometimes edoxaban might not be the ideal choice in that case. Drug interactions, go through a detailed drug history. Any drug the patient is on, cross-check with the recommended recommendations to see will there be a significant interaction. It's important because we are not monitoring, as opposed to warfarin. Warfarin you are monitoring with the INR, but in these patients we are not monitoring levels. So it's important that you get these things very clear cut. Otherwise, you will have bad outcomes. Then finally, discuss with the patient how often the patient wants to take the drug, what about giving IV first, what about taking it food, what about other bleeding, so on and so forth. Right, so then switching to switching to a Dwack, very simple. So if you're on a warfarin, you check INR after about 2 days. When it's less than 2, you can start the Dwack immediately. If you're on unfractionated heparin, wait till the infusion is over. As soon as the infusion stops, because the half-life is about 1 hour, start the Dwack. Low molecular heparin, wait for the next dose. So if you're on a BD dose, 12 hours early. If you are on a single dose, 24 hours later, take the Dwack at the next scheduled dose. Then finally, arrange a follow-up for the Dwack patients. As all oral anticoagulants, educate them about the risks of bleeding, about taking it properly, etc. Document in their clinic book, or ideally give a card which says you're on anticoagulants and this particular type of anticoagulants. So anyone who starts new drugs will know what to do. Standard recommended follow-up is after you start, you see the patient in 1 month, and after that, every 3 months should be adequate. At each visit, review the indications. Indications change, evidence change as we go on. So always review the indications. Check if there are any bleeding events, if there are any thrombotic events. Check the renal function, especially in elderly or patients who have labile renal functions, such as diabetic patients and so on. So might have to dose adjust. One thing I forgot to mention is about liver disease. So when it comes to liver disease, severe liver disease defined as Child-Pugh stage C, it's a contraindication for Dwacks. Then finally, review any new drugs that the patient was started on. And as always, check for adherence and any new side effects. So this is where I would suggest there are about 4 articles from the European Heart Rhythm Association about practical use of Dwacks. It's got that extensive list of drugs, which is quite useful to refer to. And then if you want to be updated about the evidence, I would suggest this article, which came about a year ago. After that, maybe there were about 2 RCTs about cancer thrombosis, but this is really a good update. So I think I'll finish there. At the end, I can take any questions. Thank you.
Thank you, Manu. Thank you, Manu, for that very clear presentation. I think we can take the questions at the end of all 3 sessions. So our next speaker is Dr. Ahalya Sivasanka. Ahalya is a lecturer and a consultant clinical hematologist attached to Department of Pathology, Faculty of Medicine, University of Colombo. And Ahalya is going to talk on a very kind of commonly found clinical problem in our day-to-day clinical practice, erythrocytosis, What do we know? Over to you, Ahalya.
Thank you, Madam. I would like to start off with thanking Ceylon College of Physicians to give us the opportunity to share our knowledge, and also our President, Madam Dr. Dhammika Gunawardena, to give me the opportunity to share my knowledge on erythrocytosis, what we know. So today talk, I will be briefly introduce the topic on erythrocytosis and also the causes of an erythrocytosis and how to investigate an erythrocytosis. So before I move on to my talk, I would like to start off with a history, how this polycythemia and the erythrocytosis have come up. So the Prof. Henry Beckwith, he is a French physician who has first described a Polycythemia Vera in 1892. So where he has described a patient with Polycythemia syndrome not due to cardiopulmonary disease. As we all know, cardiopulmonary disease can associated with erythrocytosis, but here he has found something is unusual. So that was the initial workup or initial reported case came in the literature. So after that, there were few additional cases have been described by William Osler in 1903. And after that, as we all know, there will be a detection of JAK2 V617F mutation that has been changed the whole world into myeloproliferative neoplasm. So in 1950, before that, I would like to introduce the word myeloproliferative neoplasm. So that was actually came up to the literature in 1951, who is Dr. William Demeshek, who has included PV in his conceptual classification of myeloproliferative disorders. So now we use the word as myeloproliferative neoplasms instead of myeloproliferative disorders. So in the 2005, where the discovery of JAK2 has changed the world, as I have mentioned earlier also, so which have explained or ratified the Demeshek's concept of myeloproliferative neoplasm. There are so many papers or an article on discovery of JAK2, so I have given some references here. You can go and have a look. So after that, in 2007, additional mutation in JAK2, which is exon 12, has been detected because almost 95% of Polycythemia Vera patients had JAK2 V617F mutation, but there are 5% of people who have had the morphology and the clinical picture similar to Polycythemia Vera, but they didn't have a typical JAK2 V617F mutation. So later on, this gene sequencing has been done on JAK2 gene, and there was a detection of exon 12 mutation. And also this is the history of how the Polycythemia Vera has come up in the literature. But there were several reported cases of erythrocytosis in relation to underlying diseases, which we call that as a secondary erythrocytosis. So compared to the Polycythemia Vera, the primary bone marrow disorder, the secondary erythrocytosis are very much common and we see day to day in life. So I'll go into my topic, the introduction of erythrocytosis. So the word itself is a self-explanatory. Erythro is a red cell. Cytosis is an increase in cells. So it manifests as a raised hemoglobin concentration or a hematocrit, or we can use packed cell volume. Ideally, to prove that there is an increased red cells, we have to do the red cell mass estimation. But that is very cumbersome and is very cost, so we don't really do a day-to-day practice. So we use the surrogate marker, hemoglobin or a hematocrit, to show that there is an increased red cell mass. So I will be talking a lot on the hemoglobin and the hematocrit, not the red cell mass, because in the day-to-day life, we go with the hemoglobin and the hematocrit. So in the packed cell volume or in hematocrit, as we all know, if you take 100% the whole blood, so we'll get roughly about the packed cell volume or cells which contain roughly about 46%. So that is a normal packed cell volume or a hematocrit we expect in an adult. So but with an increased PCV or a hematocrit, so it can be either true or an absolute increase. So that means if there is a real increase in the red cell mass or a volume, then we call that as a true or an absolute erythrocytosis. Whereas there is no increase in red cell mass, but when you see in the full blood count, you see the increased PCV or a hematocrit. So that's purely because reduction in the plasma volume. So which in this picture you can see, if there's a volume is reduced, then that will mimic your PCV is high. So then we call that as a relative or a apparent erythrocytosis or a polycythemia. So the etiology classification, as I mentioned, we classify broadly the true polycythemia or a true erythrocytosis or the relative or apparent erythrocytosis. So it's a further classification of true polycythemia. As we know, there is an increase in red cell mass. It could be primary or it could be due to secondary. Or there is a separate entity called idiopathic erythrocytosis, where we exclude all the primary and the secondary causes. Then we conclude that if we can't find any underlying causes, we conclude that as an idiopathic erythrocytosis. So in the primary classification, the Polycythemia Vera, so which is a myeloproliferative neoplasm, is a clonal disorder, and there is an inherited conditions which called primary familial and congenital erythrocytosis also comes under primary polycythemia. So I will be dealing later the causes according to this etiology classification. So before that, why we should know the erythrocytosis? So why should we study about it? Or what is the importance or a clinical significance of erythrocytosis? Purely, as we all know, because this small percentage of this erythrocytosis can end up having polycythemia vera. So that is because we have to really investigate the patient or a person whoever comes with a high hemoglobin or a hematocrit, because purely for detection of myeloproliferative forms. So why the importance of looking or detecting the myeloproliferative neoplasm? Because it's associated with one of the risks is a venous thromboembolic disease. Not only venous, it can present with arterial thrombosis as well. Like stroke or MI, they can present with that. So that is one of a key complication of having a polycythemia vera. And moreover, this disease can transform into either myelofibrosis or a acute myeloid leukemia. So because of those things, you wanted to detect the polycythemia vera as early as possible. And also we have magic drugs with us, which we can control the disease and we can prevent them getting a morbid thromboembolic phenomena. So that's because we want to identify the small group of polycythemia vera. So the prevalence of polycythemia vera was 22 per if you take the 100,000 population. So very rare, but it has a very dangerous or a very complicated complications. So purely for that, you wanted to investigate if somebody comes with a high hemoglobin or a hematocrit. So what is the definition of erythrocytosis? So there are two schools of thoughts regarding the cutoff level of hemoglobin and the either packed cell volume or a hematocrit to suspect the erythrocytosis. I think this is the few more slides which is coming up is very important for you all as a clinicians, because the patient comes to you first, and when you see the full blood count, you will get alarm saying that, oh my gosh, this patient having a hematocrit of this and hemoglobin of this. But for that to say, you should know what is the cutoff level. We have to beat alarm and alert. So in the 2008, the World Health Organization, there's a classification system for myeloproliferative neoplasms, which got revised in 2016. There were a few changes in the cutoff level for hemoglobin. I will go in the next few slides. And the British Society of Hematology guideline. So basically we have WHO criteria and the BCSH, or the British Society of Hematology guideline. So in the 2008 World Health Organization, they have given one of the major criteria is the patient should have a high hemoglobin and the hematocrit. So why this cutoff level came up, because they say if the red cell mass is more than 25%, it goes up from the mean normal predicted value, then that is significant. So which it will be predicted by our surrogate marker hemoglobin and the hematocrit. So that's because this level has come up. So the hemoglobin of more than 18.5, and you have to remember which it's in relation to patient sex, whether it's a male or whether it's a woman, the cutoff level is vary. So if it's a men is above more than 18.5, where the hematocrit is equal to 55.5%, or for a female, more than 16.5, the hematocrit is 49.5, then you have to beat alarm, because that's if that particular person has more than that cutoff level, that is fulfilling one of the major criteria to diagnose the Polycythemia Vera. So you have to alarm at that point, and you have to send the referral to hematologist and say, oh, look at this, what this patient is having. So that is the point that you have to get alarm. And I'm not going through these each and every criteria because I think it's not relevant for here, because I have put here just to show this cutoff level, how it has got varied later on. So in the guideline of the British Society of Hematology, so which was published in 2018, is a recent one which we have, where it showed the patients with the persistently raised venous hematocrit is more than 52% for a male and more than 48% for a female. That's roughly equal to the hemoglobin of more than 18.5 for a male and 16.5 for a female. So which is more or less similar to our WHO criteria. So initial days, we actually accepted that this cutoff level to use in the clinical practice, saying that if somebody comes with this hemoglobin or a hematocrit above this level, you should do a proper referral and you have to seek a proper advice from the hematologist and rest of the workup. So what happened after that? In the 2016, the WHO has revised its criteria, where it showed hemoglobin is more than 16.5, which is for a man, and the hemoglobin of 16 for a woman, or the hematocrit is 49% more than that for a man, and the 48% for a woman would do for investigating the erythrocytosis. So which is for a man, there is a drop in hemoglobin by 2 because its initial, it says like more than 18.5, now it has dropped to 16.5. So why they got revised their criteria? Because there are few internationally recommended research have happened, and one of this is a masked Polycythemia Vera, which came up from this international study. So where they have said there is and also there's another study, Polycythemia Vera, from new and modified diagnostic criteria, because there is a certain quite significant percentage of people have been missed by having a Polycythemia Vera has been missed by using the previous criteria. So here, which I have highlighted here, roughly about 14% of patients who actually had JAK2 V617F positive mutation, but their hemoglobin and the hematocrit is not fulfilling the criteria which have been laid by the WHO or a BCSH. So this is quite significant number of patients have been missed out from the diagnosis. So if we have missed these patients, then they will come up with all the complications and might come with a transformation. So that's because the criteria has been changed, and in the 2016, they have said we have to have some low threshold to pick up these people, like hemoglobin of 16.5 for a man and the hemoglobin of 16 for women. So in the revised, but the BCSH, the British Society of Hematology, they kept as previous one. So they didn't really change it. They kept it on the same hematocrit and the hemoglobin for diagnosing criteria. So after revising that, so there is an advantage because, as I have mentioned, we can pick up the people who belongs to masked or a missed polycythemia group by keeping the low threshold for an investigation. But at the same time, there are so many disadvantages also, because we usually see for the even with the secondary erythrocytosis, we commonly see the 16.5, 17 of hemoglobin and the hematocrit, and people started to alarm just seeing the figure of the hemoglobin and started to refer to hematology, saying that please exclude the myeloproliferative neoplasm, where it's not indicated sometime. Okay, because in few more slides, I will be highlighting the causes for the polycythemia or erythrocytosis. Then we'll get to know what are the common causes we day-to-day life in our clinical practice we see. So there are disadvantages because it's a cost and the cumbersome for the patient, for an unnecessarily we investigating for the patient, taking blood and taking all the sort of a genetic test and things to look for without a proper clonal disorder. So actually in our practice, we are keeping still the standard of BCSH cutoff, like hematocrit is more than 52% for a male, whereas the hemoglobin is 18.5, and the female for more than 48% and the hemoglobin of 16.5. But in few instances where we bit relax on accepting the patient for investigating for polycythemia, even though their hemoglobin and the hematocrit is not to this cutoff values. For an example, if somebody is coming and you have excluded all the possible causes of the secondary erythrocytosis, then of course you have to go and investigate that patient. So what I'm trying to say is, if you see somebody who is coming with less than this cutoff values, you can get the detailed history and examination. Even you can work it out for looking for any secondary causes. Then if you couldn't find anything, of course, then you can refer to us to look for any primary disorders. So still we are using this cutoff. So I think it's worth to remember this, what the cutoff that we are currently practicing here. So then we'll move on to the causes of an erythrocytosis. So this is the from the guideline, the diagnosis and the management of Polycythemia Vera, where they have given causes according to the Etiology Classification, which I have showed before, the primary and the secondary, where it's an inherited and the acquired conditions. And this is also more or less the similar, which I got it from one of the textbook, is Postgraduate Hematology, which is the 7th edition. It recently came up. So that's also nicely given all the possible causes for the person to get the erythrocytosis. So primary, so mainly the congenital, as you all know, something is wrong with the red cells, like there's mutations, and acquired is a polycythemia vera, which most of us are worried about it. And the secondary is a congenital again, and again the acquired causes. So here you have to know this list of secondary causes of secondary erythrocytosis, which is the commonest cause that you all come across. So the simple, even in the history taking and then examination, you can exclude most of those secondary causes. So that is very important before you jump and refer. If you just see the full blood count and referring to that patient to the hematology is pointless. We'll also do the same workup again with the history and the examination. So I'm not going through one by one here the listers, but I think it's worthwhile to know the list of causes for secondary and the primary. So it's a little bit about the pathophysiology. I'm not going into detail because it's going to be the boring section of here, the pathophysiology. But polycythemia vera the problem is the autonomous production of the red cell. There is no control over the production because of the mutation, the genetic mutation. So the mutation, the V617F mutation, and then exon 12, both in the pseudokinase domain of JAK2 gene. So usually they are the genes held for the inhibition of production of red cells when there is a overproduction. But if those genes get mutated, then there won't be any inhibitory for the production. So there will be an uncontrolled autonomous production of red cells will give rise to polycythemia vera. And also not only that, and the Polycythemia Vera erythroid progenitor cells are having an increased sensitive to growth factor, not only the erythropoietin and also other growth factors as well, like interleukins and things. And the secondary ethnocytosis, again, you classify like whether appropriate production of erythropoietin or there is an inappropriate production of erythropoietin. So if the patient having chronic hypoxia as a compensatory, you will have more red cell production. So that is an increased erythropoietin for some purposes. So that is an appropriate production of erythropoietin. Whereas in some tumor or some other like polycystic kidneys and things, there won't be any reason for the erythropoietin production. So it's inappropriate production of erythropoietin give rise to more and more red cell production. Again, that's also a problem for the person. So the inherited and the congenital erythrocytosis is problem is an intrinsically it get overactive. So that's because you ended up having erythrocytosis. So the clinical manifestation, your patient most of the time is routinely we pick up the high hemoglobin and the hematocrit. So it's an asymptomatic because they do the full blood count for something else and then it's detected to be having high hemoglobin or a hematocrit. But otherwise, in your clinical practice, you would have seen patients who complain with coming with a complaint of hyperviscosity, like headache, dizziness, and sometimes they come with a stroke or TIAs. Then you do a full blood count and you have to see whether there is any erythrocytosis or not. And of course, this is a typical aquagenic pruritus is one of typical presentation or symptoms for Polycythemia Vera, because they typically describe after bathing, they started to having itching. So that is aquagenic pruritus, which is more towards the Polycythemia Vera. And not only the thrombosis, they can sometimes present with a bleeding as well because of abnormal platelet function. So stroke, yes, is a commonest way of patient present to you. And there's a hemorrhagic strokes, or sometimes they come with a GI bleeding. And these are other rare presentations like gout, and because of the increased cell turnover, or sometimes they present with an iron deficiency. So once you started to treat iron deficiency, then your hemoglobin and the hematocrit started to jump up and creep up. Then you alarm it and say, oh my gosh, for this iron deficiency I have treated, now his hemoglobin and the hematocrit have jumped up. Okay, so and sometimes they present with a gastric acid production with a peptic ulcer disease and things. So there are various ways of presentation, but commonly in our day-to-day life, we see or we pick up most of the patient as a routine blood test. We pick up them having a high hemoglobin or a hematocrit. So how to investigate an erythrocytosis? So that's a big question to us. If somebody comes with that, what I'm going to do? So don't jump and refer to the hematologist in the first instance. So at your level, when you see the patient, you can start to work upon around him. So the erythrocytosis is a common reason. We, of course, get the referral. And usually it's a secondary origin because after taking history and maybe examination or after doing a preliminary investigation, we would have found, oh, this gentleman is having some secondary cause, not the primary. So that is a common way of presentation, the secondary erythrocytosis. And as I have mentioned earlier, the referral threshold for a very good iron storage patient is packed cell volume or a hematocrit is more than 52 for a man and the more than 48 for a woman. We still strict on that cutoff. So detailed history and examination are one of the crucial steps to identify underlying cause. So there is a proposed algorithm by British Society of Hematology to investigate erythrocytosis. It's nicely explained. I think it's not clear here. So I'll quickly go the stage 1 investigation and the stage 2 investigations. So before we order investigations, the history is very important. I'm keep on stressing again and again. The simple history taking is giving more information regarding that patient's erythrocytosis. Age and the dehydration, of course, which you can pick up easily. And the smoking, then not just asking smoking won't help. You have to ask how frequent and how many cigars or what the smokes he gets per day and how long he is smoking. And of course, the alcohol history and the detailed drug history, because that is one of our commonest, another cause we used to see. and also the sleep pattern, obesity patients, and any sleep disturbances, sleep apneas, whether they have those sort of histories, and any comorbidities, any history of congenital heart diseases. Obviously, you can pick it just looking at the patient. If come with a cyanotic heart disease, you can easily pick up them. And any previous history of thrombosis is very important. Not only it's help for the diagnosis as well as for the risk stratification of Polycythemia Vera patient. And any constitutional symptoms suggestive for malignancy, because you can get secondary erythrocytosis associated with any malignancies. And the respiratory symptoms, of course, the COPD, whether the patient have any symptoms of that. And the family history of erythrocytosis is just to see any familial erythrocytosis running in that patient. And of course, the early satiety for just to see any splenomegaly and any evidence of hyperviscosity symptoms, because that is really you have to attend that patient immediately if someone comes with the hyperviscosity symptoms. So examination, I'm not going through one by one here. So the height and weight is important just to see whether he's an obese patient and whether he's having any sleep apneas. And sleep apnea, of course, patients, sometimes they can't tell. You have to ask from the partner then he is a patient who must be knowing this snoring and things like that. And of course, cyanosis you can easily pick up. And the hepatosplenomegaly, any abdominal masses, and of course the cyanotic heart disease and evidence of any chronic lung diseases. So the stage 1 laboratory investigation, which most of the things you all can arrange it at your level. For the full blood count and the blood film, of course the blood film we have to see it, but you can send it to us and we can have a look. And serum ferritin is very simple investigation just to make sure he's having iron replete patient. And then arterial oxygen saturation, just to make sure he doesn't have any hypoxic or a chronic hypoxic lung diseases. And liver function, renal function, erythropoietin level, serum calcium. And JAK2 V617F mutation is a stage 1 investigation. Of course, that we have to arrange it from the hematology side. So for that, you can send us a referral and ask for it. So the further investigation, the stage 2 investigations is depend on the results which you get it from the stage 1 test, and then accordingly you will ask some of the very sophisticated investigations. Of course, the red cell mass, which we don't do it here, and ultrasound abdomen is a very simple thing you can ask for it, and exon 12, and like sleep studies and lung function test, and of course you have to get a help from the hepatic team and the renal team to look for any causes related to ethrocytosis. When you do these investigations, especially when you suspect secondary ethrocytosis. And of last is an NGS panel, so that is next generation sequencing gene panel to look for congenital erythrocytosis. So I'll go through another, I think, couple of or three, 4 slides I have just to quickly go through the treatment of patient with an erythrocytosis. Of course, this varies with the underlying cause for his erythrocytosis, whether it's a secondary or it's a primary. So I have started off with secondary because this is commonly we see day-to-day life. So hypoxic pulmonary disease, which is COPD or obstructive sleep apnea syndrome. So in COPD, erythrocytosis is defined when there's a hematocrit is more than 55%, and incidence is you see 6 to 8%, and obstructive sleep apnea, the incidence of erythrocytosis you see roughly about 1.7 to 8%, so which is a bit of a significant percentage of people they get it. So in the COPD, of course, you have to get help from the respiratory physician for the consideration of long-term oxygen therapy or alternative therapy to improve hypoxia, because if you take it out that hypoxic dry, then erythropoietin will suppress, then you won't get the erythrocytosis. So that's a simple basic principle of managing COPD. Take it off the underlying cause, just improving his hypoxic condition. So, of course, if the patient is on smoking, you have to ask the patient to stop it. You have to strongly advise on that. And, of course, if the patient, though they have the erythrocytosis, because that is kind of a compensatory for them, but still, if they have more than 56% and if they have a hyperviscosity symptoms, of course, we wanted to take it off some blood by doing a venesection. So in order to bring the hematocrit roughly about 50 to 52%. But don't bring it too much, because if in erythrocytosis in these two conditions is a compensatory. You need some support by increasing the red cell mass for the oxygen carrying capacity. So you don't really want to bring down something close to 45. So you want to keep it somewhere around 50 to 52. And of course, the obstructive sleep apnea, which you can manage with a non-invasive continuous positive airway pressure for reduced erythrocytosis. So simply in the secondary erythrocytosis, the basic principle is take it off the underlying cause which contributing for the erythrocytosis. So cyanotic congenital heart disease, of course, they don't really recommend hematology to take a decision for whether to take it off with some venesection or not. It's purely depend on the cardiologist's decision. So always you make sure you get their opinion too before you touch the patient or taking some blood. So the post-transplant erythrocytosis, I think is another commonly we come across when there is a hematocrit more than 1%, more than persistent for more than 1 month after the renal transplant. You call that as a post-renal transplant erythrocytosis, and incidence is quite 5 to 20% of people can have this post-renal transplant erythrocytosis, and usually they develop within a year of transplant. And it's a good thing is it's self-limiting. The patient gets spontaneous recover maybe after 2 to 3 years time. But still, if they have some symptoms or if they have a problem having with an erythrocytosis, of course, you wanted to get some blood out by doing a venesection and target the hematocrit somewhere around 50. But otherwise, it's best management for post-renal transplant erythrocytosis is give some AC inhibitors, which will help to reduce the hematocrit order. So that's a good thing, which just giving a drug you can reduce the hematocrit. And even not only the post-renal transplant, which we commonly see it, but you at the same time you see after the stem cell transplant or the combined renal pancreatic transplant also you see, which is quite significant percentage of people can get it. So the post-hematopoietic stem cell transplant, you have to take it off the blood by doing a venesection, try to keep hematocrit somewhere around 50. So the idiopathic erythrocytosis, this is mainly I'm just touching the primary causes. Idiopathic, of course, I mentioned earlier the diagnosis of exclusion, and the only thing is you don't recommend the cytoreductive therapy, which we do with the Polycythemia Vera patient. So that is a bit slightly different from the Polycythemia Vera management, and mainly you give venesection, and there is no well-recognized trials are not there to recommend how much the target hematocrit to keep it, but arbitrarily we keep it somewhere around 55. If patient had any previous history of thrombosis, or you wanted to keep it bit down somewhere around 45%. And the other thing is try to control the vascular risk factors like diabetic, hypertension, and smoking, which easily we can lifestyle modification, which we can do it easily. And of course, you can consider giving aspirin. And congenital erythrocytosis, again, the low dose aspirin. And venesection, of course, like you can give it when there is symptoms, or if there's an asymptomatic patient who had a family history of having the same genetic lesion and had a thrombosis, you can target the hematocrit to bring it bit down for this patient by keeping somewhere around 50. But there is a JAK2 inhibitor, ruxolitinib, also placed for congenital erythrocytosis, especially for CHUS polycythemia, which we can consider. So Polycythemia Vera, as we know, low-dose aspirin we do give just to prevent of thrombosis. And also the venesection, we try to keep the hematocrit target less than 45%. And of course, the cytoreductive therapy with hydroxycarbamide, which is one of a common drug that we use it in our clinic and in our patients. Again, that depends on the risk stratification of polycythemia patient. And also there are other cytoreductive options too. It depends on the age and what are the comorbidities. We can choose one of the cytoreductive therapy. And always you make sure you try to modify his other cardiovascular risk factors, because that's just try to prevent getting some thrombotic phenomena. And ruxolitinib, of course, you can use it as a third line or a second line of treatment for the polycythemia vera. If they have not tolerate or for the hydroxycarbamide and interferon, you can think about giving ruxolitinib as well. So maybe we talk a lot about the polycythemia because the prognosis-wise, it has a 10 to 20% of risk over 15 years following a diagnosis of PV to progress to myelofibrosis. That is one of the dangerous things. And other is a 20% risk over 20 years PV to transform to acute myeloid leukemia. But good thing is PV is most of the time we diagnose somewhere around 60s. Their age are 55 and 60s, so they have just 15 years, 20 years more. Nothing going to happen for those. But in a real practical life, the patients, they don't really suffer with myelofibrosis or the transformed AML because they die of natural death. So the take-home message, this is my last slide. Though ethocytosis is a common reason for referral to hematological services, it is usually the secondary in origin. I'm keep on stressing that because it's a secondary causes which can be excluded or diagnosed, just getting a detailed history and examination and very basic investigations. So the referral threshold for iron replete patients are hematocrit persistently more than 52%, where the hemoglobin is more than 18.5 in men and for more than 48% in women, except the few instances where the low threshold of hemoglobin is also used to investigate them, especially if patient had any thrombotic histories or whether all the possible secondary endocytosis has been excluded from that patient. So the common secondary causes that we see day-to-day life, obviously the dehydration, smoking, hypoxia, and maybe the drug history diuretics. So please get the history properly and try to elicit these features. And the cause can often be identified from the, as I have keep on mailing history, examination, and the stage 1 laboratory investigations. Intervention is not always indicated, and decision to insect is often made individual basis, and then underlying cause for his ethrocytosis. And polycythemia vera is rare, but only thing we worried because it has an increased risk of thrombosis and progression to myelofibrosis or leukemia and requires specialist hematology management. Thank you.
Thank you, Ahalya, for that detailed, clear presentation. Our last, the third and the last speaker is Dr. Shanika Vitarana. Shanika obtained MBBS from University of Sri Jayawardenepura in 2004, MD in Hematology from University of Colombo in 2012, and she obtained FRC Path from Royal College of Pathologists in 2015. She's currently working at bone marrow transplant unit at Lady Ridgeway Hospital for Children, and she's currently the country advisor for Royal College of Pathologists. Shanika is going to talk about another common problem that we encounter. She will be talking on raised serum ferritin. Over to you, Shanika.
Good afternoon, everyone. First of all, I would like to thank Ceylon College of Physicians and Sri Lanka College of Hematologists for giving me this opportunity to take part in specialty updates. So I will be talking on raised serum ferritin. So basically my talk would be like to what is serum ferritin and how do we test it and where the instances you get the causes of raised serum ferritin and a little bit on how to manage high hyperferritinemia. So this is a structure of ferritin. It is a protein. It has apoferritin shell, which consists of H-ferritin, which is a heart type, L-ferritin, which is the liver type. So basically this protein sequestered iron in it. So it also functions as a ferroxidase. It converts ferric to ferrous iron and it acts as a buffer in intracellular compartment where it sequesters iron inside, and because if the iron is free in the cell, it can generate reactive species, so it can damage DNAs. So it will prevent this damage by sequestering iron and acting as a buffer. So basically, the ferritin is a protein that is involved in storage and release of iron. Actually, it is not a transport protein. Iron is transport via transferrin, not by ferritin. So it is a storage protein. And it's found in almost all cells in the body, but it has high concentrations in reticular endothelial system, whereas in bone marrow macrophages, spleen, and liver. In normal individuals, 1 microgram per liter of serum ferritin is equivalent to 8 milligram of stored iron. So how do we test serum ferritin? So basically, it is serum ferritin. So you test a serum sample. So there are several methods. Most of the time we use immunoassays, ELISA-based method to check serum ferritin. So we need a vast range of linearity because in practice, we come across very low level of ferritin as well as very high level of ferritin, for example, about 40,000. So you need to have a good linearity in those testing methods. And also sometimes I think you have seen reports with ferritin, they just mention more than 2000. But we need to know an exact ferritin value because it is quite important in practice to decide on treatment and to decide whether the treatment is working. To see the response, we need to have an exact value. So actually, if the laboratory can do the dilutional methods, you can get an exact value for those higher levels. So why are we worried about this hyperferritinemia? Does it always reflect the iron stores? No. As we all know from the medical school days, the ferritin is an acute phase reactant. So it's acute phase protein, so it can get raised due to various causes like infection, inflammation, or any type of tissue damage can cause high ferritin. So it doesn't always reflect the iron stores. So if the ferritin is high, it doesn't rule out iron deficiency or indicate iron overload because it can be high due to various other inflammations. But if it is low, if the ferritin is low, you can diagnose iron deficiency anemia. But in the other way around, if it is high, you cannot confirm that the patient is not having iron deficiency. So these are the few causes of hyperferritinemia. There are 3 groups where you get high ferritin synthesis, the hyperferritinemia, without significant iron overload. So those are the causes are most of the time related to acute infections, chronic infections, inflammatory conditions, autoimmune disorders, malignancies, and so on. And the second group is the increased ferritin as a result of cellular damage. So the examples are chronic excess alcohol consumption, liver cell diseases where you get the liver cell damage, and hyperferritinemia occur. The causes for that are liver failure, chronic viral hepatitis, alcohol, NASH, and so on. And this is the important group where you get hyperferritinemia with iron accumulation. So that you have either primary iron overload or secondary iron overload. Primary iron overload which is a hereditary type, where you get hereditary hemochromatosis. And the secondary iron overload occurs most of the time due to either transfusions, recurrent blood transfusion for anemias like thalassemias and other chronic anemias, like even in kidney disease patients, when you repeatedly transfused, you get high ferritin level. And also in ineffective erythropoiesis. For example, sideroblastic anemias, myelodysplastic syndromes, and sometimes when you take excess amount of oral iron, also you get hyperperitonемia with iron overload. And there are some rare genetic disorders which you can get, which can be in this group. So out of all these causes which I mentioned before, the commonest causes are most of the time related to the infection or this inflammatory acute phase reactant. It's related to this acute phase protein process. So they are commonly chronic inflammatory or infective causes, liver disease, alcohol, malignancies, and renal disorders. So you should, like, if you get a patient with high ferritin, you should think whether the patient is having, whether this is due to acute phase protein reaction or whether this is actually associated with iron overload. So, and keep in mind, commonest cause for hyperferritinemia is most of the time due to acute phase reactant. And just to give a little bit about hyperferritinemia in hepatic disorders, the two types of causes for hyperferritinemia occurs in hepatic disorders. One is due to a liver cell direct damage from alcohol or non-alcoholic steatohepatitis. It is due to the liver cell damage. The other one is when you consume alcohol chronically, your hepcidin levels goes up, and then the iron absorption is increased, and iron deposition in the liver cells get increased. So that is how you get hyperferritinemia in liver diseases. Same with the viral hepatitis. So in renal disorders, most of the time you have come across and you have seen most of the patients who are on end-stage kidney disease patients who are on dialysis have raised ferritin, but they are anemic and they require transfusions, and sometimes they are on erythropoietin stimulating agents. That is because, like, most of these patients have functional iron deficiency, where you have iron, but you cannot incorporate that iron into erythropoiesis. So especially when they are on erythroid stimulating agent. So in these cases, this high ferritin doesn't indicate your actual available iron stores. So for them, you need to have some novel parameters in diagnosing the actual iron level, like whether the patient is iron deficient. You need to use these novel parameters like percentage hyperchromic cells and reticulocyte hemoglobin concentrate. And of course, in infection and inflammation, due to increased interleukin, especially interleukin 6, interleukin 1 alpha and 1 beta, you get raised ferritin. That is basically due to increase in hepcidin level. What happens is when the hepcidin is high, it will increase absorption of iron from the gut and decrease release of iron from the reticuloendothelial system. So you get functional iron deficiency. So we know some of the causes for high ferritin. Then we need to know what is the cutoff value for this high ferritin for further investigation. So hyperferritinemia is defined by WHO guidelines recently in 2020. They recommend a ferritin concentration exceeding 150 micrograms per liter in menstruating women and 200 micrograms per liter in men, and non-menstruating women who are otherwise healthy may indicate a risk of iron overload. Similarly, in VSH recommendations in 2018, their cutoff value is more or less similar, but for the male adults, it is a bit higher, 300 to 400 micrograms per liter, and for female, it is 150 to 200 micrograms per liter. So That is the cutoff value recommended by WHO and BSH. So in Far Eastern population, most of the time, ferritin is 1.5 times higher than the compared to white population. So what is markedly elevated serum ferritin? It is usually defined as a ferritin which is more than about 10,000 micrograms per liter. That is like, it can happen if you are a chronically transfused patient, more than 10,000 is commonly you can see if they are not having proper iron chelation. But in the other hand, if there's an ill patient, or if there's a patient who are not on transfusion, if they have this markedly elevated ferritin level more than 10,000, then you have to think whether that is associated with rare conditions like adult onset Still's disease or hemophagocytic lymphohistiocytosis, which is called HLH. So HLH is a fatal condition. So you need prompt intervention. Therefore, you need to investigate for secondary causes and to confirm the diagnosis of HLH if you see a very high ferritin level. So how do we investigate? So when you see a patient with high ferritin, you must think whether the patient is having iron overload. Because if the patient is having iron overload, the management is different. So it is important to ask this question whether the patient is having iron overload. And also you need to look for, if the patient is having iron overload, you need to look for whether it is primary or secondary, or whether this high ferritin is due to acute phase reaction or tissue damage. So in investigation wise, first thing you do is when you see a high ferritin report, don't jump up and do further investigation. First, you repeat the serum ferritin test with inflammatory markers, because that is the most commonest thing that you come across in the day-to-day practice. So if the ferritin is high and confirmed, then you go for transferrin saturation levels and UIBC, which is can be also used in deciding iron overload. And also you can do these ancillary testing like full blood count, because you need to know whether this is a secondary hyperferritinemia or secondary iron overload. You need to check for the hemoglobin. Even if it is associated with liver disease, you can check for the platelets that can be low sometimes in some liver conditions. And you need to do the liver functions, renal functions, HbA1c and ultrasound scan to check for the liver. So if we take the transferrin saturation, so you can take the cutoff value of 45. If it is less than 45, iron overload can be excluded and no further evaluation is needed, because it says the transferrin saturation less than 45% with normal serum ferritin has a 97% negative predictive value in excluding iron overload. But if it is high, if it is more than 45%, it indicates iron overload, and you need to investigate to determine the cause and degree of iron overload in this patient. So this is just a diagrammatic representative of what I've explained earlier from the BJH guideline. So if you see a raised ferritin above the cutoff value, you do the basic transferrin saturation test and the full blood count and liver functions. And then depending on the transferrin saturation, if it is high, then you investigate towards causes of iron overload. It can be either primary or secondary iron overload. And if the transferrin saturation is normal or less than 45, then you consider whether this is associated with alcohol excess, inflammation or metabolic syndrome or tissue damage. So once you investigate for them, and from the history, examination, and investigations, once you excluded them, still if your ferritin is high than this cutoff value, and if it is very high, if it is more than 1,000, then you need to assess whether there's any actual iron deposition, because initial phase of hemochromatosis, primary hemochromatosis, can present in this way. And if it is less than 1,000, then you can repeat the testing again and follow up the patient. So what are the causes for iron overload? As I mentioned, there are two types: primary iron overload and secondary iron overload. This list is from the gastroenterology article, and that is basically explain about the secondary iron overload. The causes include, as I explained earlier, thalassemias, aplastic anemia, where you get recurrent transfusions, and hepatitis C, alcohol, non-alcoholic liver disease, where you get liver tissue damage and causing hyperthyroidinamia as well as iron deposition, and also malignancy and cause iron overload. So why you need to find whether the patient is having iron overload? What are the problems with iron overload? Excess amount of iron in tissue is toxic. So when this excess amount of iron get deposited in the tissues, they are toxic to the tissue and get damage and can cause organ failure. Especially, they deposit in liver, endocrine organs, heart, joints, and skin. So how do they present clinically? So you need to have a good clinical history and examination to look for organ involvement in iron overload. So, but most of the time they have vague symptoms. So commonly the iron overload patients, they present with liver iron or deposition, and they can present with raised liver functions and hepatomegaly. The important thing is this can lead to hepatic fibrosis, cirrhosis, and even hepatocellular cancer. So you need to identify liver iron deposition early. And the next commonest thing is endocrine organ involvement. Most of the patients are hypoglycemic and has diabetes because iron will disturb the islet cells of the pancreas, and also because of the hepatic iron deposition, they can be insulin resistant, so that can give rise to hyperglycemia. And also the heart deposition of iron in the heart is less common in type 1 hemochromatosis, and they can give rise to cardiomyopathies and arrhythmias, and also can involve joints and skin. So this is again a diagrammatic representative from about the primary hemochromatosis taken from the SCG clinical guidelines. And so, as I said earlier, raised ferritin with high transferrin saturation, then you need to investigate for a iron overloading cause for hyperferritinemia. It can be either primary or secondary, and then depending on the cause, you have to treat. So if you are like having a iron overloaded hyperferritinemia with iron overloaded, then you need to think whether this is primary. So if it is primary, this is the several causes of primary hemochromatosis, and the commonest is HF gene mutation, where C282Y mutation and the H63D mutation. You can do the genetic panel and confirm the primary hemochromatosis, type 1. There are other types also. So now you know the patient is having iron overload. Then you need to find the degree of iron overload. So basically serum ferritin is used in secondary hemochromatosis, where you get secondary iron overload in thalassemias, but it has a good predictive value, but still it can be increased due to infection, inflammation, and various other things. So that cannot be used as that cannot be used alone to monitor to determine the degree of iron overload because of that. So there are other tests, liver iron content. Yes, earlier days it was used, taken a liver biopsy and stain with pearl stain and detect the iron content. But it is an invasive procedure where it has the risk of bleeding and perforation. So because it's an invasive procedure, we no longer do that unless you need to find whether there is liver fibrosis or whether there is hepatocellular cancer. The good test here is T2 MRI of liver and heart. By doing this, you can identify liver iron content as well as cardiac iron content. In T2 MRI, you can distinguish primary hemochromatosis pattern of iron overload from the secondary iron overload. In primary, it's only the liver gets involved. In secondary iron overload, you get both liver and spleen involvement. So a little bit about the management of iron overload. If it comes depending on the cause, you need to manage the iron overload. If it is primary, where you have a good hemoglobin level, the first line of management is phlebotomy. Phlebotomy to keep serum ferritin between 50 to 100. Once you achieve this target value, you can increase the gap between phlebotomies to maintain this level. And there is a study which has shown with pre and post hepatic biopsies that doing phlebotomies in moderate to mild cases with iron deposition in the liver that has improved the liver iron content with phlebotomies. So phlebotomy improves abnormal liver tests and heart dysfunctions. But it will not improve arthralgia or like the joint involvement and endocrine involvement. So erythrocytophoresis is like plasmapheresis. You selectively remove red cells by connecting to a machine. That is a good way because you can remove larger volume than the venesection, but it is costly. And there's this randomized control trial has shown the use of PPI in patients who are on venesections that has reduced the number of venesection over a period of 2 years because PPI reduce the absorption of iron, thereby reducing your iron deposition. And when it comes to chelation therapy, that we use drugs, we use desferrioxamine, deferriprone, and deferricirox. So those drugs usually used in anemia-associated iron overload conditions where you have recurrent transfusions and dyserythropoiesis. In those conditions when you have iron overload, you can use oral chelation therapy. In primary hemochromatosis, this is not the first line therapy because there are limited number of studies in those population with these drugs. So the take-home message is serum ferritin is an acute phase reactant. So it can be high due to various other reasons. And also you have to, when you have a patient with high serum ferritin, it is quite important to think whether this hyperferritinemia is associated with iron overload or not. If it is associated with iron overload, you need to investigate thoroughly to find the organ involvement. And transferrin saturation coupled with serum ferritin is a good indicator of iron overload. These are the references. So thank you.
Thank you, Shanika. Now, this is the question and answer session. We got 2 questions. What are the Dwacks that used as Vte prophylaxis?
So there are, for Vte prophylaxis, we have to use the lower dose. I think what they're referring to is after the first 3 or 6 months. Beyond 6 months, the doses that we can use. So we can use apixaban at 2.5 milligrams twice daily, or we can use rivaroxaban at 15 milligrams daily. Those two are the licensed one. Although edoxaban has a lower dose of 30, it is not licensed to be used as prophylaxis. Also, dabigatran also doesn't have a prophylactic dose for yeah.
Yeah, thank you. And there's another question. This is to Shanika. Is it safe to use long-term PPI in iron overloaded, as it can lead to chronic kidney disease?
Actually, they have said like they have used about for 2 years. The studies have shown about 2 years, and they are not telling that to use it as a primary treatment modality. But if you covered it with the venous sections, that can improve the increase the gap between the venous sections. So basically, you can give a short term and see whether the patient is like having an improvement with that. Only 2 trials are there.
Those are the only two online questions that we received. Is anyone in the audience need to ask a question?
Can I ask from Manu, how do you kind of intervene Dwack prior to surgery, say minor surgery or major surgery, sir?
Thank you, madam. So that is one part I didn't touch in the lecture. So mainly you have to consider two things. What is the bleeding risk of the surgery? So they have categorized high bleeding risk, moderate bleeding risk, and minor bleeding risk. Then you have to look at the creatinine clearance and the excretion. So it's like a 2x2 table where you put on one side your creatinine clearance, and on the other side you have the bleeding risk of each surgeries. So depending on that, you have a specific time period to stop the DOACs. For example, for somebody who goes for a minor surgery with creatinine clearance more than 60, you just stop the the DOAC for 6 hours. Or apixaban, because it's a BD dose. If it's rivaroxaban, you stop it for 12 hours. So if your creatinine clearance is between 30 to 60, you will probably stop the drug 12 hours before for the same surgery. Similarly, if the surgery is a high-risk surgery and your creatinine clearance is good, you'll stop it at 24 to 48 hours. But that person if that person has impaired renal clearance, the duration you have to stop the DOAC will be 48 to 72 hours. So it's depending on the bleeding risk of the surgery and your creatinine clearance, you have specific time points to stop the DOAC.
Saying somebody has to have a bone marrow in the morning and the last dose was the previous day morning, so that will be the last dose, I suppose.
Yes, ma'am. So bone marrow, as we don't really, unless it's a very technically demanding one, we don't consider it as a high bleeding risk one. So omit the morning dose. That's it.
Thank you.
There's another question. Is serum ferritin is a sensitive marker for iron deficiency anemia?
If the serum ferritin, if it is low, you can say that is iron deficient. But for example, as I said, like if you are having other diseases like kidney disease and anemia of chronic disease with the iron deficiency, you cannot just go by the serum ferritin levels. So you need to have either like other markers, like you can do the iron studies like serum iron and iron binding capacity, and also the novel parameters like hyperchromic microcytic percentage and reticulocyte hemoglobin. Those would be the best thing in those instances.
Yes, Shanika, I think you have answered the next question as well. What is the best investigation for iron deficiency anemia and iron overload? Honestly. Yeah, thank you. So I think we have come to the end of this question and answer sessions. On behalf of the Ceylon College of Physicians, I would like to thank all three speakers for their wonderful lectures. And may I cordially invite Dr. Manu Vimala Chandra to receive the certificate of appreciation. Dr. Ahalya Sivasanka. Dr. Shanika Vitarana. Yes, and finally, I would like to thank Dr. Dhammika Gunawardena, the president of the Sri Lanka College of Hematologists, for their support and co-chairing with me today this session. And also, I would like to thank Professor Senani Williams. She is the coordinator of the Ceylon College of Physicians for the hematology all these sessions. Although she is not here, I would like to thank her on behalf of the Ceylon College of Physicians, and also our sponsors, CIDES, for their support throughout this year. The all 11 specialty updates that we conducted for the year 2021, and the staff of the ClinMark for their wonderful job and for their maximum support with all these facilities and so on. And also Nalina and your team. And Nalina has given a marvelous support throughout this year with all these audiovisual and well as the Zoom links and so on. And thank you, Nalina and the team. And we are waiting for the next year as well, right, to continue this your continuous support. And also the staff of the CCP for all these who worked with us and who left with us, and all the other pre-interns who worked with us and for their maximum support during the year 2021. And so the continuous support is also we are going to expect with the next council. And finally, I would like to thank all the college presidents, secretaries, and also the coordinators of our council for their support and in various ways to hold these specialty updates, college lectures, and most of the other events. And I would like to thank all the participants here physically, as well as there are more than 160 online participants in each and every specialty updates that we conducted during this year. So finally, and on behalf of the Ceylon College of Physicians and on behalf of the Council of the Ceylon College of Physicians, I would like to thank all, namely not in mention, but for all the people who have supported us during this year 2021, and we continuously seeking your support for the next year as well. Thank you so much.